So we've given people a chance to join. So a very, very warm welcome to this Catalyst seminar. Thanks to Professor Essie Vidding, who was the catalyst who got us going with these with this seminar series. And I'm David Osborne from the Division of Psychiatry. So I'm a psychiatric epidemiologist, but my only job today is to introduce people and hopefully keep us organised and to time. So we've got a really interesting couple of talks today looking at data science and how it can contribute to understanding of children and young people's mental health. We were going to have 3 speakers, but unfortunately Ruth Blackburn, who was going to join us with Ruth Gilbert, is unwell. So Ruth has heroically agreed to present both Ruth's slides and her own slides. So Ruth, the first talk will be from yourself, and then we'll move over to Jess Deighton. And then when we're finished, Tobias Hauser from the Max Planck Center will be our discussant and bringing a cognitive neuroscience view to some of the data science that we're going to hear about. So if you're okay to start off, I introduce Professor Ruth Gilbert, who's a clinical epidemiologist at the Institute of Child Health, but also co-director for the NIHR Children and Families Policy Research Unit.
Okay, so thank you. Thanks very much, David. Can you all see my slides okay? Yeah, good. Okay, lovely. Thank you. So thanks very much for inviting us to speak about using linked administrative data to inform policy and practice for mental health in children and families. And sadly, Ruth Blackburn, who's done lots of this work, cannot be with us today. So that's down to COVID and being worse than expected. So I'm going to present 5 examples of epidemiological studies of mental health presentations to primary care and to hospital care and how we measure that in administrative data. I'm actually not going to present any work using mental health services data, but I know Jess Deighton's going to talk about that after, and many others here will have more experience with that data. So administrative data comes from a variety of sources. It can be drawn from the coded part of patients' electronic health records, such as in primary care, or from clinical record systems, such as in mental health data. And these records are clinical data, clinical records, because they're used during patient contact. Another source for administrative data is hospital episode statistics, which are collated and coded by a professional coder and primarily used for administrating the service. So data feeds from both of these, or from many other sources in fact, are used for administrative purposes such as costing, monitoring service delivery, but they're also widely used for service evaluation and research. So these secondary purposes usually involve de-identified data with no re-identification allowed. The use does not involve patient consent, but does require that the purpose will benefit patients and the provision of healthcare. The other point is that these data are often linked. So linkage of healthcare contacts or events over the life course for each individual create really valuable longitudinal healthcare trajectories of healthcare use. So hospital episode statistics, or I'm going to call it HES from now on, captures all hospital contacts over 2 decades. And it's particularly valuable for children because we can follow them from their birth in HES to adulthood, and in this example to a girl's pregnancy in HES as an adult. So primary care data also allows really long follow-up, but it's not nationwide. It's fragmented by GP computer system providers. And then the other very valuable thing is that linkage of more specialist clinical record systems, such as mental health systems, into HES is particularly valuable, so that researchers can see how, who's selected into those services and what their outcomes are after they leave those services. But a huge advance for us in research has been linkage of children to their mothers. And this was established in HES now about 7 years ago by Dr. Katie Harron at UCL. And there's a similar linkage available in primary care. So what this means is we can follow the health trajectories of girls from before pregnancy, during pregnancy, after pregnancy, and the trajectories of their children from birth. And we can also, therefore, obviously, compare siblings. Lastly, these data, there's many of these data sets now, but particularly HES being linked to other databases, and the eChild database I'll mention later has been linked to education data and to social care data for all children in England. One other example that I won't have time to go into is of mothers involved in family court proceedings. So that's provided by an organisation called CAMHS, which has been linked to mental health clinical record system at South London and the Maudsley. And that's now a linked resource that we've created together with Johnny Downs at SLAM that's available for reuse for research. So my first example of research is research conducted by Shabir Saeed, who's back working with us at UCL. And that was to develop indicators of adverse childhood experiences using these linked mother-child records in primary care and also linked to hospital episode statistics and mortality. And we heard yesterday that's now in press in the Lancet Digital Health. So we're really pleased about that. So the aims of this study were to first of all develop clinically relevant ACE indicators of adverse childhood experiences, and then secondly to determine the prevalence of these in mother-child pairs. So adverse childhood experiences, you will know, have been associated with poor health outcomes persisting well into adulthood. The concepts include child maltreatment, including all types of physical, sexual, emotional abuse and child neglect. And the other concept that this brings together is household dysfunction. So it includes measures of parental mental disorder, parental conflict, intimate partner violence, parental separation or death, and criminality. So this study used a cohort of 264,000 mother-child pairs, so over 500,000 actual individuals from 400 practices in England. And we used information from the cohort of mothers up to 2 years before birth and then up to 2 years after birth. In fact, there's follow-up to 5 years in the paper, but I'm just going to show you results over those 4-year periods before and after birth. And these are critical periods for maternity and child health services to be monitoring families where there may be particular concerns. So in a nutshell, because this was a very large amount of work that took a long time, in a nutshell, the indicator development had lots of iterative steps that used literature review to develop the concepts, mapped them onto codes that were in the primary care and in secondary care, and then to identify what Shabir identified was 408 potential indicators that were then assessed in prediction models and by an expert panel. So those 408 indicators were assessed in prediction models against an internal reference standard of definitive codes for child maltreatment and intimate partner violence. And then those were whittled down to 63 ACE indicators that were consistently associated over several, it was 8 different sort of prediction methods and across the expert panel as well. So here's some results, and overall, as many of you will know, I think, is that the ACEs are very highly prevalent. So in this population over this period of 4 years, 39% of mother-child pairs had one or more ACE indicator recorded. Maternal mental health problems, you'll not be surprised, were at the top. They're the most frequently recorded in 22% of mother-child pairs. Adverse family environment indicators accounted for 15%, so that was the next most prevalent. And that indicator reflects things like child is a cause for concern, code that GPs use, homelessness, family disruption, and parental conflicts. And a common one was high-risk social factors in pregnancy. And you'll see from this graph that maternal substance misuse prevalence of 7% there, and of child maltreatment or intimate partner violence much lower, 3.1% together. So a very important finding from this study was that ACEs were captured mainly from the maternal records. So if we'd only used child records, 72% of ACEs would have been missed. This finding is really relevant to practice and should encourage GPs to scrutinise records of household members where there's concerns about a child or about a parent. And then, not surprisingly, ACEs were mostly captured by the primary care records. So if we'd used only hospital records, we would have missed 62% of ACEs. My next example is a study led by Ruth Blackburn together with Astrid Gutman in Toronto, Ontario, and this aimed to determine the 10-year mortality of mothers whose infants had neonatal abstinence syndrome. So opioid use is rarely recorded in hospital or GP records, but opioid withdrawal symptoms require intervention in the baby and will be recorded in the baby's hospital records. So that's what Ruth was using here. And she devised a cohort for England of babies born in 2002 to 2012, whose infants presented with NAS, and then a control cohort of infants without NAS. And the same approach exactly was used in Ontario. So mothers were then followed up over 10 years post-delivery. So mothers were linked to their infant records and then followed with linkage to death registration to capture mortality risk. And what we found in this study was that it used 4.2 million births and mothers, and just about 1 million in Ontario. NAS prevalence was 0.3% in England, 0.5% at that time. In Ontario, it's gone up quite considerably since. And you'll see that these survival plots are remarkably similar in England and Ontario. So by 10 years after delivery, just over 5% of mothers had died in England and just under 5% had died in Ontario. And this is 11 to 13 times higher than the mortality rate in the control population. But the other thing we've found, which is of interest, is, of course, mortality among mothers with any admissions for mental disorders before delivery. Mortality risk was very high. So even among the no NAS mothers, you can see that deaths in those with addiction admissions before birth or other mental disorders before birth were really very high. And in terms of the total numbers of them, because this is a very much bigger group than the NAS group, there were more deaths in these. So the clinical message from this is the need for ongoing follow-up and support for mothers of infants with NAS and for the larger group of mothers with previous admissions for mental disorders. So I'm now going to move on to Ruth's part of the talk. And here I'm going to talk about mental health among adolescents, covering the period, the age from 11 to 24 years of age. And this is a time of biological, psychological, and social change when there will be many indicators of mental disorders in adulthood that first appear in adolescence, and when we'll see peak levels of distress behaviour. And most of these distress behaviours will, of course, not present to healthcare, and certainly not to hospital care, which is what I'm going to show you here. So we're very aware that we're dealing with a clinical iceberg of distress signals, and we'll only be seeing the very top of that. So, for example, with self-harm, community self-report studies show that around 1 in 10 young people will self-harm, but in hospital, we'll only see those that are severe enough to require emergency admissions, and even those presentations will be skewed by the type of harm. So we'll see more poisoning coming into hospital, less cutting, and there may be other factors like involvement of adults or teachers at school who make presentation to hospital more or less likely. But what I'm going to present to you here is some work done by Annie Herbert some years ago, but we're building very much on these codes. And what she devised was a set of, if you like, phenotypes of what we called adversity-related injuries, which captured intentional self-harm, drug and alcohol misuse, and violence presentations to hospital. And she devised an accidental injury group as a comparator. And what we were, so the underlying premise here is that how these behaviours present to hospital and how they're coded or recognised may well depend on the circumstances or the sequence of events that lead to these young people getting into hospital. So there may be shared underlying psychological or social risk factors and similar or prognoses, or at least in some subgroups. So that's why we were looking at these separate groups and bringing them together, because the other thing is they get managed very differently. So those with intentional self-harm will, if they're admitted, they under 16, they're required to have be seen, at least at the time of this study, be seen by a child psychiatrist before being discharged. But in the other groups, then there's no such sort of strict requirements. In NICE guidelines, there's some mention of management of alcohol dependence, and there's no specific guidelines about the management of violence. So this is how they overlap, and of course they're very different in girls and boys, with much more overlap between drug and alcohol misuse or a bit more in the girls, but still a lot of overlap in the boys, and then violence being more prevalent in the boys, but less overlap with the other two. The point to make here is that these admissions affect 4% of all boys and girls across their adolescents from 11 to 17, so they're quite common, and they account for half of all injury admissions in girls and a quarter in boys. So they're a big problem among hospital admissions. So we looked at their prognosis, their 10-year prognosis for deaths here, and you can see that risk of death, this is in boys, is highest for those with self-harm, but also a highly increased for violence and for drug and alcohol admissions. Similar patterns compared with accident admissions, the one on the left. And then we looked at the cause of death. And what you see here is that nearly two-thirds of the deaths were related to either suicide or drug and alcohol misuse. And in fact, what Annie showed was that following drug or alcohol presentation to hospital, there were equivalent risks of dying after this. These were all deaths after discharge from hospital. The equivalent risk of dying from drug or alcohol misuse as of suicide. And the same was true for admissions with self-harm. So this suggests that for effective strategies for suicide prevention, then suicide prevention needs to be targeting young people presenting both with alcohol or drug presentations as well as self-harm. And these interventions should also include consideration of interventions for drug or alcohol misuse. So moving on now to mental health in schools. So you're all aware mental health in schools is a major problem, a government priority. And there's a big question about how schools influence adolescent mental health. So I'm going to talk about some work that Ruth and others have been doing on stress-related presentations. And the first aim here was to develop indicators of stress-related presentations. And so these are defined as emergency admissions in which the primary diagnosis was a stress-related code, and we've developed that based on literature reviews and clinical input. But in broad terms, there's three concepts here. Pain-related admissions, so particularly abdominal pain, where that's the primary cause of the admission, mental health and behavioural admissions, and other somatic presentations. So the second aim was then to look at whether these patterns of admissions were higher in school term time compared with holidays. So this is a summary of a lot of work in the graph that you can see on the right. And you'll see that in term time, there's a very steep increase with age for girls, and it's much higher than holiday rates, the rates during holidays for girls shown by the dotted line. And then the rates for stress-related presentations for boys are much lower than girls, but there is a higher rate during term time than for holidays. So nearly 8% of all girls and 4% of all boys had a stress-related presentation admission between the ages of 11 and 17. So again, significant burden of problems. And these accounted for 31% of all emergency admissions, including entry admissions. So very high proportion of hospital burden. And they're predominantly mental health and behavioural or pain related. So taking that phenotype that we developed, my last example is some work that we've been doing with a database called eChild. In a nutshell, this brings together the National Pupil Database, which includes all education modules, attainment tests, special educational needs, absences, plus social care data, so looked after children, child in need, episodes and so on, with hospital episode statistics. It's been brought together, we've led that work in UCL. We're hoping to make this database available more widely. And it links nearly 15 million children across the whole of England. So the aim of this study, and this is hot off the press, work done by Louise McGrath-Lone, was to compare the prevalence of emergency hospital admissions with stress-related symptoms or signs in children receiving statutory support. So those are aged 11 to 16 with a social worker, so either a child in need or looked after, or receiving special educational needs support, and the comparator group is peers with no support. And what Louise showed was that, first of all, stress-related presentations, first of all, that statutory support is very common. 35% of pupils have one or other between year 7, so age 11, and year 11 to age 16 years, so very common. And of those, then 1 in 5 had special educational needs only, 20%, 7% had social care only, and 8% had both. And what she found was that the risk of the risk of stress-related presentations was much higher in those that had both special educational needs and social care support than in those with no support. And there's a gradient that you can see here. And also common in those with more intense support from social care. She also showed that the predominant type of presentation was that in the mental health and behavioural category, particularly for those involved in with social care support, but there's still a gradient that you can see through the pain-related and the other somatic presentations. So I want to finish with just summing up a few points about administrative data and using it for mental health research. So administrative data make a really important contribution to the sort of population perspective of mental health, and are very important for shaping policy. The strengths and weaknesses centre on its collection as part of routine care. So a strength is this is comprehensive capture of data through services and comprehensive follow-up. So you don't have the attrition that you have in recruited cohorts or surveys, because it's capturing anyone who uses the services. Another advantage is that the administrative data reflects presentations to services. So findings can be directly then related to what clinicians, or what should change in practice, how clinicians can identify these patients, but it doesn't reflect occurrence in the community. So variation in access to services and variation in quality of data and recording are important sources of bias that we always have to think about. There is some availability, as you've seen today, of relevant mental health measures. There's scope for linkage that we might have a chance to talk about at the end, but there's undoubted access challenges and analytic challenges. So I want to just acknowledge our funding and collaborators, and then at the end you'll be able to have these slides. There's some of the references. So I'll stop sharing there. Thank you very much.
That's great, Ruth. Thank you so much. It's such a wide-ranging demonstration of the power of these data for answering so many different clinical research questions. So fantastic work. You make it all sound so straightforward.
It's not. It's long and painful.
Thank you. The plan is to have our discussion and questions at the end. I was going to say, if there's any burning questions in the chat, I can't see anything right now. So if people think about things that they would like to ask Ruth about all that work, then we can get to that at the end. But I'll say thanks to you for now, Ruth, and then introduce our next speaker, which is Professor Jess Deighton, who is a professor of child mental health and wellbeing at UCL, with also roles in the Anna Freud Centre. But Jess, I'll let you see if you can start screen sharing.
Thanks so much. This is always the most nerve-wracking bit, because it didn't quite go according to plan in the dress rehearsal, but fingers crossed. There we go. It's working now. Thanks so much, David. Yeah, really nice to see everybody, or know that you're there, even if I can't see you. As David said, yeah, I'm based at UCL, but I also work across UCL and the Anna Freud Centre, which is a child mental health charity. So most of my work focuses on that. And I think Ruth's given a brilliant sort of tour de force of all whole range of work in the area of administrative data sets. I think I might be speaking more to the pain of the process of this presentation. But this is just to give one example really of a piece of research we did that I suppose illustrates the neatness of when we can do these data linkages, what we can achieve and the questions that we struggle to answer without it. And I just wanted to acknowledge this is a paper not led by me, but my colleague Jess Deighton, who's not able to join us today, but was also in collaboration with others who are here with us, including Essie and David. So I wanted to start just by taking a step back. I know this is probably familiar territory for many of you, but I think it's just helpful to remind ourselves what we know from population data, because a lot of the way we understand prevalence and need, I suppose, quite often comes from these sort of broad statements from population data about children's mental health. So we were in the dark for a decade or so as to what was happening, but had some great prevalence data in about 2018, telling us that around 1 in 8 children and young people appear to be experiencing mental health problems in the UK. And that was a bit of a jump from the last estimate, which was around 1 in 10. I suppose the bit that I find might be nice to sort of draw out for this piece of work is that what they also asked young people as part of that process was, and their parents, was about, of those who were sort of showing those difficulties, who of them were accessing specialist mental health support, so child and adolescent mental health services. And only 1 in 4 said they were accessing that kind of help. And I think interesting to note, particularly based on some of Ruth's work just reported there around schools, possible source of stress, schools also potentially a source of support, and young people quite often report that if they're experiencing mental health struggles, they will go to teachers to talk about that. So, so both sides of the coin. What we also know from population data is a bit about the risk factors for mental health problems. So this is by no means a exhaustive list, and I usually share some qualitative quotes, which I don't have time for today, but just to give some examples, we know that financial and economic hardships contribute to mental health struggles, that conflict in the home, be it between parents or between parents and children, also has an impact. We know that there's increased rates of mental health problems for children who have special educational needs, for children who've experienced bullying, for children whose parents have mental health problems, also those witnessing or experiencing domestic violence in the home, and those who are from neighbourhoods that feel more unsafe or sort of threatening or violent, I suppose. And recently we've also learned more about COVID and the associated lockdowns and their impact on children and young people's mental health. Particularly, some updates to that prevalence data I mentioned seem to indicate that mental health problems have risen in the population of children and young people, and it's now looking a bit more like 1 in 6 are experiencing mental health problems. And that's stubbornly staying around, actually. So there's been 2 follow-ups that have both shown that kind of rate of problems. So that's all from the sort of population data side. But the bit I wanted to focus in on a bit more for this piece of work was that group that are accessing specialist mental health services. So there's quite a lot of curiosity around who accesses this kind of specialist help and who doesn't. So what do the 3/4 versus the quarter look like? And I suppose going back to Ruth's example of the iceberg, that's sort of, it's the above water and the below water sort of aspects of the iceberg, I suppose. And that's something we sometimes struggle to do. So we probably have a lot of questions about that. So we know, as we've just seen from those data, that lots of people with mental health problems don't access specialist help. There's clearly a gap, and seems to be increasing, between the level of need and the support that's available, and there's an increasing squeeze, which can sometimes mean that CAMHS is absolutely prioritising managing risk rather than sort of tackling all levels of mental health challenges after they've met a particular threshold. But also there is another consideration, which is that young people sometimes want to access help from different sources, or might find other sources helpful, like accessing it within their school or within their community. But also that naturally, when we talk to young people about how they manage their mental health, and this is probably true for all of us, we've done this in qualitative studies, and they have talked about drawing on supportive relationships around them. And if those relationships feel sufficiently robust, actually that can help them to manage in a way that they wouldn't have been able to without, and might mean that they don't need to access those other sources of support. And also young people talk a lot about self-initiated forms of support, so how they sort of self-manage their mental health. And that's not to say that that replaces specialist support, but sometimes that might be enough for some young people, or that might be their preference. But we still have a question about who attends. So is it therefore, based on what I said before about this sort of squeezed kind of resource, is it that those with the most severe symptoms are the ones that present? Is it those who struggle to sort of derive meaning and enjoyment from life because perhaps they don't have those other supports, that it's really impacting on their quality of life? Is it those that actually might have been identified to others in the system already because of other additional needs? So maybe they're in contact with social care, or perhaps they have been in contact with youth justice, or perhaps there's already sort of additional special educational needs there. And also in the literature, there's evidence that those who perhaps have more agency or ability to navigate their way to support that's on offer are sort of able to access that, where others might sort of struggle to do so, or certainly might struggle to do so in a way that feels like it's self-initiated, like through GPs or other sort of self-referral sources. And yeah, they'll often come through like youth justice or other kinds of referrals. And I think the challenge is that we've got information sitting within sort of community data sets that tells us something about general need. And that's all of the things that I just mentioned, really, about what we know about prevalence and even that bit about who, you know, what proportion access help. That all comes from those data sets. And then we have CAMHS data sets, which tell us a bit about, you know, we can describe the populations within those, but we can't often sort of bridge the gap between those two and say, can we find the same people in the population data set that we can find in the CAMHS data set? And I think what we have been able to do, what we have been able to move forward with some of those, is add a bit of colour and depth potentially to what we can make of those different data sets by being able to make particular linkages. So for lots of community and population data sets, we're getting very good at linking to the National Pupil Database, which Ruth mentioned earlier. So that's the sort of administrative data collected by all schools. It has information on a range of characteristics for children and young people, including their special educational needs, their free school meal eligibility as a bit of a proxy for economic deprivation, their deprivation scores for their neighbourhood, and it also has information about their educational outcomes, their school attendance, their exclusion rates, and their academic attainment. So it's quite rich and useful. So that's something that's been sort of relatively straightforward, but it's been quite hard to do that within a CAMHS setting because just the read across between health data sets and education data sets has always been incredibly challenging. And we've been very lucky for the beginnings of this particular project. We were able to draw on a piece of work that had already been done with Johnny Downs and other colleagues at South London and Maudsley, where they've been able to approach the National Pupil Database to link their mental health service data with National Pupil Database data. So the NPD provided that linkage service and then gave SLAM back a data set which was sort of only includes sort of pseudonymized IDs, but linked their caseloads, if you like, to the National Pupil Database. So that was a very laborious process that had already been carried out. And what that allowed us to do for this particular project was to actually find a group of young people in common across these two data sets, both linked to the National Pupil Database. What we found was that we had a community data set, which I'll say a bit more about in a minute, which covered the same geographical area to some degree as the South London and Maudsley data set, and that we actually held in common that pseudonymized ID, which meant we were able to find the same young people in those data sets, which was felt nothing short of miraculous at the time. So just to give you a bit more of a sense of what we were able to get from that process, we started by, as I say, we've got this over here, the sort of service data. This targeted mental health in schools is the population data. It was collected over a period of 3 years, and we looked at a period of 3 years in the service data as well. But what we were able to do is, across those commonalities, we managed to make these linkages. You can see that the data sets are quite large when they get to those two positions that I talked about before. By the time we combine the two, the overlap is quite a bit smaller. We had about 2,500 cases. And then we found there were a number that we couldn't use because the period of time that was covered didn't quite match. But we ended up with a matched sample of over 2,000 children and young people. And then from that, we could see those that had not accessed CAMHS and those that had. And it's a small group, but it's still a meaningful group. And what that allowed us to do was double down a bit on those questions, really, about what do we want to know then about that group? We have a population where we have population survey data about mental health and well-being and quality of life. We have the richness of the MPD data sets, and we also have information from the service data. And I would say we were probably quite modest in what we accessed from those service data, because really we were just interested in who accessed CAMHS. So what we derived from that data set was simply, did they have a successful referral to CAMHS, essentially? And we were particularly interested, I suppose, in how well the mental health status of those young people, based on their own report, corresponded to access to CAMHS. But we were also interested to see whether quality of life had a particular bearing. And thanks to the National Pupil Database, we were also able to explore whether there were other factors like having special educational needs or being from a deprived background that might also predict accessing CAMHS. And what we found was that, that once we'd controlled for various sort of factors, there were a few predictors, but not as many as we might have expected, I suppose. So some of the usual suspects came up in that those young people who had a status of having special educational needs were much more likely to access CAMHS. Now, that might be partly because they're already on the radar, if you like, for teachers and others. But it also probably means that there is an actual category within special educational needs, which is to do with emotional and behavioural difficulties. So the crossover might be due to commonalities there. Also, we did find some indicators of economic deprivation predicted access quite significantly, but not all. So free school meals probably would have predicted if we just put it in on its own, but actually deprivation based on area was the most striking, and that was particularly comparing those in the most deprived quartile to the least deprived. In terms of the mental health measures, what we found was actually the reports of emotional problems didn't predict access to CAMHS, but behavioural did. And we thought that was quite interesting. We don't have a good, well, we can't really unpick exactly why that is, but we reflected perhaps that it might be something to do with the fact that emotional problems can quite often go under the radar, whereas behavioural problems will come to the attention of certainly school staff, if nobody else. But interestingly, quality of life, where this was reduced, that did predict access to CAMHS as well, and almost to a similar magnitude, I suppose, as behavioural problems. So I think that fits with a sort of, I was going to say a hunch, it's more than a hunch, an expectation of mine, I suppose, that quality of life and sort of being able to derive meaning and satisfaction from life, even in the context of mental health problems, is probably quite a significant predictor of whether you need external help or not. So I think the fact that that came out really sort of supports that possibility for me. So just to kind of sum up then, I think what we found from this was that symptoms definitely play a role in terms of predicting access, but that's definitely more on the behavioural side than it is on the emotional, and that quality of life seems equally important. That often gets overlooked and missed out, I think, when we're thinking about how well young people are functioning or managing. Economic deprivation, special educational needs, unsurprisingly, were the strongest predictors. But yeah, just this, it left us with a bit of a thought really about, does this reflect, you know, who's on the radar? Is that what we're finding? Is this the kind of, you know, those who get access are perhaps the ones that are most overt or most kind of, you know, others around them might be most sort of aware of. But yeah, but there's probably more to unpack in terms of quality of life and how we can use that to understand a bit more about who's managing and who's not managing. And I suppose final reflections in terms of linkage is, yeah, we just absolutely can't grasp the nettle on these questions without this kind of linkage. And this whole study sounds very simple, but from the very first linkage, we're probably talking a 12-year process. So we definitely need to get better at being able to do that to answer these important questions. The other barrier is lack of routine population data. So if we're going to do this really well, we also need good data sets to link to, and there's just not good national data on child mental health and wellbeing in the population at large. And yeah, I mean, the more we had things like that, the more we could replicate these studies at scale. But at the moment, I think this gives just an illustration of the possibilities, really. Okay, I'm going to stop sharing there.
Yes, brilliant. Thank you so much, and highlighting the power of this linkage, but also some of the problems that I suspect will be mentioned as we go into discussion. So yeah, thanks again. I can't see any instant questions in the chat just now, so I think our plan now is to hand over to Tobias Hauser from the Max Planck Center for Computational Psychiatry and Aging. So Tobias, the floor is yours to let us know your thoughts.
Thank you. Thanks so much for the lovely talks and giving me the opportunity to be the discussant here. Yeah, there are loads of thoughts about each specific example of your work, but I guess I'm a bit of the odd one out here because I am not an epidemiologist, and so all of that is very new, and the whole process is very new, but very, very interesting. And so rather than reflecting on what we heard in terms of the results, I want to take a step back and try to see how can we bring these different fields together. And I start off just by quickly describing what we do in our work, and then asking you guys very naive questions about first about the process and then how could we bring these things together. So in my lab, but in our center, we're very interested in understanding what are the cognitive and neural mechanisms that are involved in mental health disorders. So what is going on in the brain and in cognition, and what is happening, which brain circuits are involved, which cognitive patterns are involved in mental health, and both in development and in adults. And the way we usually do that is by having, well, compared to your sample sizes, tiny, small samples where we have a few dozen, let's say, patients and a few dozen controls, and we put them in an fMRI scanner and we look at brain activity when they are solving a certain problem, and we've tried to find differences. Now, obviously, this is very much reduced, and we are nowhere close to even controlling for effects like you were discussing, like all of these different factors will influence the mechanisms. So more recently, we've moved beyond the lab to try to get bigger samples using mostly citizen science approaches, where we take our tasks that we usually use to understand cognition and we turn them into games where everyone can download on a smartphone app, for example, and play them. And by doing that, we get tens of thousands of people to play our games, which is very big data for us. It's still small compared to what Ruth has shown with 500,000, although some of these approaches have been there. Obviously, there are limitations like convenient samples and so on. And so, in a way, what we are doing in our small-scale studies in the lab, but even just on a bigger scale, like with cognitive testing, would be fantastic to have it on the scale that you guys have the data and access to. So my kind of idea or my thoughts are like, how can we actually bring things together, like epidemiological population databases? Is there a way of linking those things up with research data which is not conveniently collected? And so my first question to both of you would be slightly just on the logistics of what Jess mentioned, the pain of the process. Because for me as an audience, I see all this wonderful data, and you alluded to that it's taken a decade or more to get any of the data. So if you could talk a little bit about what is the actual process, how do you go about to get these databases, to bring them together, and maybe also what are the ethical implications, because obviously these people don't sign up to the give informed consent. So can you just tell a little bit about the logistics there?
Okay, shall I start, Jess? So the logistics are improving, and the use of administrative data during COVID has been very useful and changed government perspectives about that. But we started working on the eChild database in 2014. It's always important to get public support beforehand, so we worked with 3 charities before we even put our applications in. Our applications went through about 3 sets of lawyers, both in NHS Digital and Department for Education. That's why it was so drawn out. We then hit GDPR and so on and so forth. But we have that data now, and what's important is that it sets a precedent for making that data available for wider use. So the UKRI funder through ESRC and through HDR UK is very keen to see databases linked and then reused more widely. We're just at a stumbling block where we're battling with the sort of legal pathways to make it more widely available. So at the moment, it's just for the UCL project that we've got eChild. So it will get better, and this approach to having linked data is seen as extremely useful, not only to science but to the health service, and quite frankly to the industrial life sciences strategy, attracting inward investment to the UK. So it's very much up there. Big data, as you know, is part of the government strategy. So it will get better, but in answer to your, I think your earlier question, which was how might you bridge the gap between these relatively crude but very large and comprehensive administrative data and the more detailed, deep, rich data that you have in individuals? I think it's really important. And one of the things that we're doing is to try to do not so much lookalike studies, but use cohorts. So increasingly cohorts like AusPac, Millennium Cohort, and UK Biobank is not relevant to children, but it is an example of a massive cohort that has rich imaging data of the type that you'll be developing, Tobias, and has sort of very detailed cognitive test data that can then be used and mapped onto risk factors and prognoses that are collected in administrative data. So, for example, within the policy research unit that I co-direct, we've got a study that is using AusPac data to look at the interrelationships between intimate partner violence, parental mental health and child mental health, and looking for critical periods in that, with that sort of detailed data that's collected in AusPac. And then we'll have a study with the mother, child, and hopefully father data in primary care to see how those relationships that we see in AusPac might be visible or not in primary care. So that's one example. And I think your sort of methods hopefully will be appearing in some of the massive cohorts being planned at the moment at UCL, the children of the 20s, and the feasibility study for another UK birth cohort. So I think that's the way to go.
Shall I just add to that as well? I completely agree. There's more political will than there was for data linkage, and its prominence in various policy documents recently, I think, has been a testament to that. And I think no small part due to the kind of work that you've been doing, Ruth, and the Pathfinder work, David, that you're leading as well. They're all really nice examples of how this can work. And when we've done consultations with young people, they have talked about wanting to feel really clear on how their data is being used, and that being really important to them, that they have some agency and understanding, but also feeling quite frustrated that they give this information is theirs and it's out there, and why can't it be used to do useful things that actually help young people like them. So I think that's something that's really important. And I know there's been some great campaigns like Data Saves Lives, but we're not very good at getting that message out about why it's important to do these things. And I think we could definitely do more on that front. I suppose one thing just to bear in mind, exactly as Ruth alludes to, these data sets definitely have huge potential, but they're also incredibly flawed. So it's also just important to remember that my colleague Miranda Wolpert coined a term, FUPS data, which is flawed, uncertain, proximate and sparse. And when I look at the CAMHS data sets, I can definitely say that's true. You get very excited about these large numbers. Tobias, like you're saying, 500,000 sounds massive. But when you look at completion rates and you link with something else, and suddenly, as you can see by my flowchart, suddenly it's very small again. And we just have to think about who we lose from the pipeline each time we link. That's problematic. And in terms of how we can make sure we incorporate these different methods, disciplines, perspectives, I think it's so important. And, you know, it would be ridiculous to ignore the potential of those things. And I think Essie's work, the UKRI, is a really nice example of how you can build those kind of layers of being able to look at the sort of broader population, but you can build in exploration of mechanisms as sort of nested into the sort of fabric of how the research works. And I think, as Ruth says, definitely with cohorts, but I'm really keen on sort of a broader approach to well-being and mental health measurement for children and young people. And I think if we can embed that in schools and then nest research on top of that, that would be really the holy grail for me.
Yes, fantastic. Thanks so much for your responses. So that takes away my next question anyway, which is good. So in the way you are just going back to it getting easier, so you're saying that it's a lot about political will to link these up, and I guess COVID has changed a lot. Is it that we can look at different countries, like for example Denmark, who are probably still ahead of us of how it's done? Is that correct, or do you think we're going our own way? When I was speaking to people in Denmark, they were really excited, and I feel like there was a lot of pride in the population itself that they're contributing to these databases. So rather than the government allowing to sneakingly let us look into the data that is collected anyway, there was a pride and a consciousness about what they're doing and the relevance of that. Is that something we are trying to do, or is it something we should try to do much more? Maybe Ruth?
Shall I answer that? Yes, they're way ahead of us, and they have been for, they've been doing this for 40 years. So there's very much a tradition of this sort of linkage, and it's not just about health data. I gather you can, in Sweden, you can look up your neighbour's tax records, for example, crudely. I've been told. They're way ahead of us, and they will always be way ahead of us in terms of the intergenerational linkages. So, they know so much and have reasonable numbers to look at parent, grandparent effects on children. So it's very valuable. So, but I think we will go in that direction to some extent. And in relation to the question asked in the chat, in Finland, the requirement is to show that before you consider any recruited cohort, by which I mean contacting somebody, or any recruited study, you have to show that you can't do it through using administrative data. So the administrative data linked across the country is seen as reducing the burden of research on individuals. So first use the administrative data, and then where there's gaps or specific deep dives, which I think the questioner in the chat is hinting at, then it, you can make a case for doing recruited research. And I think we're away from getting to that point, but I think that's the point we should get to. And that specific question in the chat kind of, an example of where we are making headway is on recruited trials. So I think some of the very large, for instance, cardiovascular trials run out of Oxford are based on using administrative data to identify, for example, cardiovascular risk, and then to have a separate trusted third party contact those patients to invite them into trials. I'd really like to, and that gives you huge power then to sort of look at, with education and health data linked up, to look at sort of specific behaviours in specific settings to recruit children that are often missed from standard cohorts and surveys, or at least lost from them if you get them in the first place. This would be a very much more efficient way of going forward. It does hit this ethical and trust issue that at the moment the rules are there's no re-identification. In fact, at hospital level and local authority level, there is some slippage in that. You can use data for service purposes, and there is some element that can be, if you need to go back to look at, you're running an audit and you need to go back and look at case notes, for example, for particular queries. So I think we should go in that direction, but we're and it's an obvious way to go, but we're a long way from it. It's all about building trust, so it's not just about government. It's about building trust, so the public engagement, and that means the public understanding of a very complex process, actually, of what happens to their data is really important.
And I think just adding to that on the trust point, it's so I mean it's like almost as complicated as the linkage, because I think in some instances it is just about being clear, being clear what happens and making that as transparent as possible. But equally, I've heard young people and families talk about where they have known that their data has been shared in a way that they haven't expected, and they felt betrayed by that. And also particularly where we've got linkages like to youth justice, that's a very, that requires a lot of trust, and that's usually young people and families where the trust has been broken, so they have legitimate concerns, and I think we really have to be mindful that those are legitimate concerns.
Real challenges in the time when we try to do open science. These are real sort of issues, like where are trade-offs between open science versus, in some cases, are you actually going to effectively bias the population you want to study if you don't sort of set these things up in a mindful way.
Exactly. And the only thing I was just going to add on the linkage is definitely Denmark and other countries, streets ahead, but equally Wales and Scotland are ahead of us on this as well. So we could definitely learn something from our closer neighbours too.
Fantastic. So I see different avenues, if I sum you up, and your points for linking brain data and cognitive neuroscience that we are using. So one would be cohort studies, as Ruth mentioned. The other point would be selective recruitment strategies, where we kind of use these big samples to identify people. And the last point, which I thought about, and obviously that is kind of a big dream, is to implement research measures in kind of general hospital use, or in these kind of in these kind of databases, which would be collected per se. I guess that would be our dream, where we could just like add our little tool into every NHS visit or something like that. But probably that is more of an utopian dream than a reality, I guess.
Not a utopian dream at all, and people have worked really hard at doing that with GP data, because you actually you see the data on the screen, you're coding it as you're seeing the patient, as you'll know from going to see your GP. So what has been tried and been very hard to make successful is to then randomize them at that point. So to have sort of at the point of care. Recruitment to studies. but that's proven very difficult. So yeah, I mean, I think you know, probably a sort of low-hanging fruit is to use the power of the massive data so that we can randomize schools or clinics or A&E departments without any sort of, you know, consent procedures. In fact, for some things where it's just sort of differences in practice that are available anyway in the population. You're just systematizing that variation.
Yeah, I think we could go on, but I think I'm mindful of the time, so maybe we should open it up. And David, do you want to lead that?
Sure, very happy to. So thanks very much for all those points that touch everything from the ethics to the trust through to the quality of the data, and of course all the governance around bringing these data sources together. There's a couple of questions in the chat. I know you referred to one briefly, Ruth. Somebody asking particularly, having worked with the National Pupil Database, and but saying, asking for sort of practical experience of working with these hospital episode statistics, which are obviously a kind of national database of all of our contacts with acute and mental health hospitals. But I don't know who wants to speak to that one. Ruth, you are.
Yeah, so shall I? So yes, we. So I'm part of the Child Health Informatics group. So if you go CHIG on UCL, you'll get the Child Health Informatics group, and you'll see, I think on that website, you should see the course on HES, that hospital episode statistics that Pia Hardley, Anya Silverstein, and Linda Vilas are running. I think the next course is run twice a year. So getting quick because they are oversubscribed. I think the next one's in May. So yeah, we run the group I'm part of runs courses on these sorts of things, and Katie Harron runs courses on linkage methods. So, and we need more of that. I mean, there's a lot of people in UCL using HES. So at least 50 data sharing agreements at this point. So yes, a lot of it.
And I think the question was, how laborious is it to work with these with HES as a data set, Ruth?
I think not nearly as difficult as with GP data. GP data is much more difficult because it's not coded in a standardized way. So, you know, you're using ICD-10 codes for diagnoses and other sort of standardized codes for procedures. So it's much more straightforward. So yeah, it's doable. It's just very large, and it's much better. I mean, I hear what Jess is saying about CAMHS data, and you'll probably say awful things, David, about other mental health services data, which you know much more about than me, which I think are very flawed. But that's not so much the case for HES. You know, you have to craft your questions according to the type of data it is, but it's really it's been going for a very, very long time, and is much better than some of these other data sets like mental health.
Thanks, Ruth. Yeah. I won't talk about. We're not talking about adult mental health services data today. We're focusing on children and young people. So I'll be quiet. Jess, unless there's anything you want to say about HES, there's another question which again speaks to this idea about kind of getting granularity into these data sets when we want to ask quite kind of mechanistic questions about mental health outcomes, and really talk about virtual cohorts and the idea that perhaps researchers could then use either education data or health data and then go in and do more comprehensive kind of data collection, be that around genetic or imaging data, or be that around social and relationship type measures. So any thoughts from either of our speakers on those?
So that's what I was referring to, because so what you're really asking for is recontact. So you identify them in the data, as the example of a trial that I gave, and then you recontact them. So you know, that's problematic, because you're then using information that they didn't know or consent to you using to then knock on the door. so it's, but often it's a very sort of non-intrusive thing, but just like sending, a letter to invite people to participate. So I think there are ways of doing this, and it needs a lot of careful work. I mean, I would say that the big thing about this sort of crude, very large database, these large databases, is they do show up the heterogeneity of mental health or whatever conditions you're looking at. So it does show you that there are numerous subgroups with different trajectories and outcomes depending on very different circumstances. So you do want to have information, from people like Tobias and so on details of the mechanisms, contexts that might influence and different interventions that might be important to start to tease apart these subgroups that are often, not visible in smaller studies. So this is definitely a way we want to go. And I think a major area for work for observational studies, as I say, it's been trailblazed in trials.
Yeah, I don't have much to add to that, just that it's good economical use of data, isn't it? And if those Scandinavian models are the ones we should be following, that's exactly what we should be doing. But it has to be built in to the expectations, I suppose, of those data. It's back to the trust question again, isn't it, really? But also bit of charm offensive from researchers that these data sets can be so much more usable if some of that flexibility was built in respectively, and now's the time to be doing it, really. Yeah.
Thanks, Jess. Well, listen, we're coming up to the end of the seminar, and I think I'd really like to thank both of our speakers, and of course wish Ruth Blackburn well with her suddenly being struck down, because she was okay yesterday, so we wish her well. But thank you both for showing really the huge power of these data sources. I mean, there are some quite shocking and important messages there about what needs to happen in terms of policy, and then really important work about the from you, Jess, about predicting people who use CAMHS services. So I think we all would like to see greater granularity, and I wonder what our wish list would be in terms of governance. But it's been fantastic. So thank you both very much. And of course, thanks, Tobias, for your thoughts about the comparisons with the data that you use. So we'll finish up there. I ought to just mention a plug from Essie in the chat that I hope everybody's seen about the next Catalyst seminar, which is on the 20th of April. Which Pravitha Patane is going to chair. So have a look in the chat and please sign up to that. But
it's on quantitative and qualitative studies of mental health in sexual minority adolescents. So really, really important topic. And can I also add my thanks to the speakers today? It's really, really interesting and informative. And thank you, Toby, for sort of adding some thoughts from the other side, so to speak, which is what we try to do in these seminars, to connect people up from different disciplines at UCL. And thank you, David, for an amazing chairing as usual.
Pleasure. We're all on the same side, Essie.
Yes, I know. This is great.
Thank you.
All
Thanks
right.
very much.
Thanks.
Bye.
Thank you. Bye-bye.
Yeah, bye-bye.